So today we have Dr. Piotr Dubrowski from Stanford University. He's a clinical educator and medical physicist. And we have Dr. Layth Mula Hussain from University of Ottawa, who I believe many of you are familiar with. And they will be sharing a presentation on the grand opening and transition into 3D conformal radiotherapy. Without further ado, I'll let Dr. Dubrowski and Dr. Mula Hussain take it away.
Welcome everyone in this first session in our course. I'm Layth Mula Hussain, radiation oncology physician. I finished my medical school in Iraq and then I did my specialty in Jordan. And currently I'm working at the Ottawa Cancer Hospital here at the University of Ottawa. It's my pleasure to meet you all in this course, which is like concentrating on the smooth transition from the 2D to 3D radiation therapy to the Middle East centers. So it's a start. The wisdom is not a product of schooling, but of the lifelong effort to acquire it and then implement it. So what's Rayos Contra Cancer? Rayos Contra Cancer is a not-for-profit organization. It was established in the United States by the efforts of an excellent group of people chaired by our colleague Benjamin Lee, who is currently doing radiation oncology residency at the San Francisco. And I'm like privileged to join the efforts and work like on volunteer base to help and spread the awareness and the training and the education of radiation therapy to the limited resources countries. So it's basically a not-for-profit organization, as I mentioned, to improve the cancer treatment in the limited resources areas globally. And the aim is to help existing radiotherapy clinics to improve. So feel free. وأي شيء يعني ممكن أنه تحتاجون توضيح ممكن أنه يعني ممكن don't hesitate to ask us to repeat or clarify, and we are here to help. We are here for you. So at the end we need you to improve the skills, and this is our aim. So don't feel shy. أنه في حياة So the 2D to 3D curriculum is a safe learning environment. So we hope to grow as a community with a shared goal. During these sessions, we are honored to work with the motivated leaders in each region who we hope to help them share education to train others who need it. It's our compassion for the high quality patient care that unites us all. It's 25 sessions, about 1 to 2 sessions per week. The variety of instructors, most teach several sessions, and some sessions will be very interactive. We want you to participate. So this is the list of the topics that we are going to finish. So we are starting by end of August, and hopefully by end of November or start early in December, we will finish this project and this training course.
Okay, yeah.
The assessment, educational. It is not for just pass or fail. It's for improvement on the personal level and the centers level. So don't worry, they are not punitive. Assignments for the clinics, systems of practice assessment. The clinic will describe their clinic workflows and documentation, and after review and suggestions, the clinics will revise the workflows documentation and present them. And more information prior to the session 9 later on. The imaging registration assessment, clinics will show their performance with the setup, phantom, and we will review these quantitatively and qualitatively, and instructions will be announced later in the course. The quality assurance assessment, the clinics will share quality assurance results, opportunity for use of image software of quality assurance, and instructions will be announced later. So it is a confidence assessment. We need to assess the confidence, pre and post course assessment for the confidence, This is include the red cap enrollment form, and similar form will be sent at the end of the curriculum, so we can like assess the level of the confidence of the participants. Competence assessment, the pre and post course assessment will be based on all the multiple choice questions based on the course curriculum. So we need like to assess this also. And the last thing may be the contouring and the planning quality assessment. We will gather each individual's performance on the Prono platform and have it to meet a certain benchmark. Clinics will have chances to upload the practice cases to receive feedback on the practice contours before they are challenged with the final practicum, sometimes after sessions 14 and 15. And these instructions will be communicated before session 13 and the imaging registration assessment. Yes, thank you.
Perfect. My name is Peter, or Piotr Dubrowski. It's very nice to meet you guys all. And I'm going to take you over a simple, very kind of high-level overview of what 3D conformal radiation therapy is. And I'm going to try to highlight as best as I can the differences between 2D and 3D. And as I go over this, if anything seems too quick or too fast, don't worry. There's going to be, like you saw, Layth mentioned, there's many sessions that you're going to go through that are going to go in a lot of detail between all the different topics. So this is just a grand overview to kind of get you an idea of what to look for and what the changes are. So a little bit of history, because radiation has been around for about 100 years or 125 years in terms of X-rays. And I really found this idea really interesting, that within months of the discovery of the X-ray, it began to be used in diagnostics basically right away. And within that same year, somebody got the idea to treat a first breast cancer patient with these X-rays. They didn't even know what these X-rays are, but they decided to use them for breast cancer. So you can see the history of radiation and cancer are basically joined right from the beginning. Over time, over the next 20 to 30 years, we started to discover that fractionation plays a key role. So delivering the dose in many fractions rather than one single dose became very important. We also invented the ion chamber, which kind of brought in, accuracy and precision to radiation therapy. The next kind of era is this orthovoltage era, superficial treatments, brachytherapy, so nothing deep, very simple single treatments, single field treatments. Between the 50s and the 80s, you began to kind of come into the megavoltage era, so cobalt units, kind of rudimentary Linacs, and then now you started to kind of come and have multiple arrangements, multi-field arrangements, in order to treat deeper tumors. And really, it's been only in the past 30 years or so that what we would call the modern radiation therapy era has evolved. And that's because of all the technology that has developed in that time. So this introduces 3D planning and some of the more sophisticated treatment approaches that we see today. And just like there's sort of a pattern or a development of radiation therapy for cancer treatments, it's also, I really love this slide because it's also reflected in how we approach radiation therapy. It's actually a skill that we build from one step to the next. You can't really jump into IMRT or 3D therapy without knowing how it was done before and without acquiring all the skills, just like a sculptor acquires the skills first at the start and eventually, gets better into creating beautiful sculptures. It's the same thing with radiation therapy. So I really love this slide. It's a great illustration. So contrasting the 2D era and the 3D era. So in the 2D era, we're looking at planar imaging, simple conventional simulation, and we're looking to create basically fields, excuse me, I'm just going to lower this, fields, pretty simple fields and generous fields, because the tumor locations, the cancer that we're trying to treat, we were not sure where it is. So if you look at this, hopefully you guys can see my mouse. If you look at this little diagram here, this blue patient, we know there's some sort of cancer within the patient, but we don't know where. So our fields are nice and wide and pretty simple arrangements. The dose calculations that we use are pretty simple as well. They're usually empirical models measured by a physicist, usually done in water, and they mostly account for the patient's shape and nothing much more after that. So despite being fairly crude, the therapeutic results are great. A lot of the clinics that treat with 2D, you're doing it because it has huge benefit to the patients. But there's a limit. And that limit is basically the toxicity that you see for a lot of the normal tissues that you're irradiating with these wide, generous fields, because we don't know where the tumors are. Contrast that to the 3D era. It really came about when the use of 3D imaging became kind of ubiquitous or became prevalent, mostly CT scanners. Now that you have a picture of the patient in 3D, you can localize and delineate and figure out where the different anatomy is of the patient, where the tumor is, where the normal structures are around in 3 dimensions. That allows you to have the ability to now choose fields in more complicated arrangements and begin to shape that high dose region, which in this case, the overlap of all the fields, where the bright yellow is, begins to shrink only around the target that you want. We also can use that CT scan in order to create a very high precision, high accuracy data calculation, or dose calculation, excuse me. And as a result, we get to increase the dose to the tumors while keeping the dose to the normal structures at the same level or reduce it. And therefore, we increase that therapeutic ratio. Basically, we get to boost the tumors and keep complications lower. So basically, we go from this, which has wide fields and kind of a mystery in here. That's why we need these wide fields and simple arrangements. Now, we kind of shine a light on the internal anatomy. We know exactly where we want the dose to go, and we begin to shape the dose as best as we can. And these are little pictures, but it's a real, giving you a real example. This is a prostate patient on the left here in the 2D era. It would be a pretty simple 4-field box, again, based on bony anatomy because we don't really know where the prostate is. And compare that to the moment we know where the prostate is and we can calculate dose and high efficiency, we can start to shape that high dose just to that target as best as we can. Now, this is a DVH. We'll cover the DVHs a little bit later on, but what you should know is that the red curves are your target. So you're in this example, your prostate. The yellow and the orange curves are your bladder and your rectum. And anything on this corner means it's getting a lot of dose. Anything down here, getting less dose. So you can see that jumping from 2D to 3D, just by knowing where you're shooting and having the ability to design the dose around that area, you can reduce the amount of normal tissues that are being irradiated pretty drastically. Now, this is obviously the start for a lot of people. It's not the destination, this is the journey. Ultimately, we want to get to IMRT because that really opens up things even more. And that jump from 3D to IMRT is actually, in relative terms, fairly simple. All you're doing is you're modulating the fields. It's the same, pretty complicated field arrangements, the same, 3D, you know where you're shooting, but now you get to modulate the fields. You get to change their intensity. And again, you will see a benefit going from 3D to IMRT. You'll see, again, a huge benefit in reducing the normal tissues while keeping your targets at the same dose level. Again, increasing that therapeutic ratio and therapeutic benefit to your patient. And really for a prostate, prostates are pretty simple in relative terms. The big benefit are things like this, where they're very complicated. Head and neck are very complicated. Again, in the 2D era, you can see the tumor or the target and the normal structures are getting relatively the same dose. 3D head and neck treatments are pretty challenging, but you can start to shape that dose a little bit around the different normal structures. But it's when you get into IMRT and all these advanced treatments that you really start to shape that dose only around the targets and prevent the dose spilling out to normal tissues as best as you can. So that's sort of the end goal, the journey that you want to go on. But these are just the beginning. So for the next few minutes, I'm going to break down 3D CRT, 3D radiation therapy, into these steps. So you have your simulation step, which you acquire a CT scan. Contouring, in which you draw and delineate the different targets and organs. Treatment planning, dose calculations. Every single one of these aspects has a lot of considerations that you have to go through in order to be as accurate as good as possible. And I want to pause here and just say, well, why is this so complicated? And this seems like a lot of steps, and it seems like a lot to kind of change going from 2D to 3D. So why is this so complicated? And ultimately, 3D CRT, you're trying to shrink the radiation from a large field with lower dose and start to conform that radiation around your target with higher dose. Well, what happens if something changes? So you saw that little diagram before. On this left-hand side, you have 2D. On your right-hand side, you have a 3D beam arrangement. Well, look what happens if a patient starts to move. You can see in the 2D era, as the patient moves, the fields, your target's going to be covered relatively well, and the treatment will be substantial. Contrast that to 3D. The moment that you have any sort of misalignment, the treatment will be, suboptimal, and probably could be even worse than if you were to treat that patient with a simple 2D arrangement. So this is what kind of I want to emphasize during this overview is that in order to gain the benefits of 3D conformal radiation therapy, you really must reduce the uncertainty along the entire process. Basically, 3D conformal radiation therapy is much less forgiving than 2D was. And again, as you journey towards IMRT and more advanced treatments, this becomes even more important. So the skills that you build here at moving from 2D to 3D are going to be pivotal when you move forward into IMRT. This happened to a lot of clinics when they first began to use 3D conformal radiation therapy for so this is, I think, from MD Anderson. They did, a study for the prostate treatments when they were moving to 3D, and they realized they had a lot of patients that were basically had a lot of, much less local control than they were expecting, almost 30% local control loss. And they looked at these patients and they wondered, well, why is that? We did everything properly. And they noticed that in these patients, for example, there was a huge amount of air in their rectums. Okay, so during the simulation scan, during that CT scan, the air was there, but obviously during treatment, the gentleman passed the gas, the prostate would collapse and it would fall out of that very high dose region. And obviously the prostates would be underdosed and therefore local control was lost. So in this case, the solution could be, well, we could just draw a larger target. We could expand that high dose range. But you'd be irradiating the rectum as a result. And so you would lose that therapeutic benefit. So in this case, instructing the patients when they come for their simulation scan in order to have no gas was the solution, because this allows you to keep your target small. It allows you to spare the normal tissues, and therefore you basically get the benefit of the 3D radiation therapy treatment. So that's sort of the lesson that I want you to take away from. In order to have the benefit of 3D conformal radiation therapy, it's very dependent on a lot of factors in that chain. Okay. So I'm going to go through each of these steps very briefly and kind of introduce and contrast the differences. I know, Ben, there's a lot of kind of hand raises. Do you want me to pause here maybe for some questions, or
no? We're doing well. I'll let you know if there are questions.
Perfect, awesome. Okay, so a simulation in the 2D era kind of looks like this, excuse me. You have, planar imaging, and you will design blocks on a conventional simulator or by hand. And, it's a regional approach. Moving to the 3D era, this all happens at the CT simulator. And you basically start off with a CT scan. So this is, patients up to this point have often had many CT scans for staging. But this is a very specific radiation therapy scan. This creates a snapshot that we will use to plan the entire process all the way through to treatment and all the way through to the end of treatment. And this gives us two benefits. One is we can actually visualize in 3D the anatomy, and we can identify targets and tissues, but also it's going to be used eventually for the dose calculation to perform a very accurate dose calculation. Okay? So this is specific to us, and we want it to be, our radiation therapy scan. Now, you can always complement that with any other information that you have. If there's an MRI or any other diagnostic scan that you have, you can always use that information, but you need your own CT scan. So a couple things for the simulation. Like I've already mentioned, there's a patient prep is very important. That's sort of a term. Basically, you're restricting or controlling the internal anatomy of the patient. So it's very important to give instructions for bladder, bowel, rectum, and stomach filling, really depending on what you're treating. You have to have some instructions for the patient so that when they come back for treatment, they're going to be, in the same internal anatomy. Things like swallowing and even respiration, how patients breathe, making sure they're calm instead of taking huge breaths, will have an impact, because the snapshot is a brief moment in the patient's history. You want that to be as representative of what the patient's going to be like during treatment for what can take weeks or up to months. But not only that, patient simulation preparation can actually assist with the further downstream treatment design. So for example, in this case too, a full bladder, if this patient's bladder was full, it could push up all the bowel out of the way, and your 3D treatment beams could traverse that bladder and have a lot less toxicity than if the bladder was empty and the bowel would fall into that region. So it really helps with treatment planning as well. Obviously, you will also have to create some sort of external anatomy immobilization. So these kind of devices, they take all shapes and sizes, and again, you'll have, there's going to be a full session on this, but they can be very complex or pretty simple. So here's an example of a head and neck mask, and here is an example of what we call a vac bag, or like a mold. And this does the same thing. It ensures that the snapshot you take at the simulation is reproducible from day to day as the patient comes back for treatment over many, many weeks. And it's also reducing the amount of motion that the patient can experience during treatment. Again, because you're starting to shrink that high dose region only around your targets, you want the patient to not be able to move as much as in the past. Caveat is the patient comfort is very important, and I'm sure the other group's going to cover that. But ultimately, immobilization and patient preparation must be clearly documented and communicated for everybody else, because downstream in the contouring and treatment planning steps, this really must be taken into consideration and must be clear what was done in order to reflect the treatment. So once you have a nice appropriate scan, CT scan, the next step is contouring. And contouring is basically just drawing out the different anatomical structures on that CT scan slice by slice. So we usually categorize them into targets or where we want the radiation to go. And this usually is done by the doctor, or exclusively should be done by the doctor, because they have that clinical knowledge of where to direct the radiation. And the other group of organs is what we call organs at risk, or OARs. You might hear that word quite often. And this is where we want the dose to kind of be avoided, or at least what we want to know how much radiation we're giving to these patients. And this can be done by the doctor or somebody that's kind of more specialized as a planner or a dosimetrist. The terms are kind of loose. But the key here is that anatomical knowledge is vital in appropriate contouring. If your contouring is accurate and consistent, you'll have a lot of benefit, and it'll definitely impact your treatment plans and your patient outcomes in the future. So this takes a lot of great skill, and it takes skill that takes time to develop. And even with seasoned doctors, in modern clinics, there's a lot of variability between physicians and between dosimetrists and planners. And so it's important to kind of have some consistency so that the patients are comparable one to another, and the treatment plans are as accurate as can be. And there's a lot of resources and atlases and guides in order to show you how to do these. So it's important to kind of follow these when you have access to them. So there's two documents that are very important for 3D radiation therapy, and that's the ICRU 50 and 62 document. They kind of set the baseline for how we do 3D conformal radiation therapy. And what they do is they introduce a couple of terms for the targets, and some of these might be familiar or not, but we'll cover them. So we initially draw our target as something we call the GTV. And this is basically what can be seen, palpated, or imaged on that CT scan. And we'll draw that out, and that's called our GTV. Next, we'll expand that out for microscopic disease into something called the CTV, or clinical target volume. And finally, there's a third expansion, which is for the PTV. And that's taking the CTV, where you're counting for microscopic spread, and you're adding a margin for all the uncertainties in the delivery and the planning and everything in between. So this setup margin is kind of, it's just an expansion, but it's very important because it has to represent what's being done before and after this step. So if you simulated a patient for a head and neck treatment without a mask, your setup margin should be huge. But if your setup margin is huge, you're kind of losing the benefit of going into 3D radiation therapy and designing these high accuracy plans. So putting a mask on a patient, restricting the patient's movement, you can begin to shrink that setup margin and basically reduce the amount of normal tissue that you're going to irradiate. And likewise, it goes down to the other end. For delivery, if the therapists are not imaging or they don't have any tight tolerances of how to set up a patient, even if you have the proper sim and the proper immobilization and the proper setup margins for or the proper planning, if the treatment is loose, your setup margin needs to account for that. So finally, the next step is treatment planning. And again, treatment planning is a huge skill. And I really want to kind of emphasize this, that it's very experience driven. So you have to have a system for proper training opportunities for anybody who's going to be doing the planning and time to develop in a safe environment. Okay, so this is, obviously everybody knows the Mona Lisa. It's one of the world's most famous paintings. I asked my daughter to draw the Mona Lisa. As you can see, there's a bit of a difference in these two, and it's all about development of skill. So I really encourage clinics that are moving from 2D to 3D not to rush this step. Treatment planning is very complicated, and it's something that you gain over time in seeing many patients and doing many plans. So it's very important to have some sort of training schedule in a safe environment. So really, treatment planning comes down to a planner, somebody who's doing the treatment planning, creating a set of beams and a set of LINAC parameters in order to best fulfill a physician's intent. So this is really important because the more specific a physician can be, the easier that planning process is going to be. So the more information you can give to the planner, the easier that planner is going to have. And usually, physicians often tend to think of treatment planning as a linear process where they give instructions, something happens here, and then out comes a plan that's supposed to be good. But in reality, it never looks like this. It actually should look like this, where the physician intent is a beginning. There should be a consultation, a chatting, with the physician, with the planner about what the intent is and clarify anything. There's the actual planning step where the planner creates these beams and looks at the dose. The physician should evaluate this dose with the planner and then provide any feedback. Is this appropriate? Is this, do we need to change something? And this cycle can happen numerous times before an appropriate treatment plan is developed. So there's a tendency to think that it's, it's like a stream, but really it's a circle that you have to iterate through a couple times. Not only will this give you better plans, but that educational piece is there too, where the planner has time to learn from from that feedback from the physician, and the physician has time to learn of what's possible and what isn't. So a little bit about beam design and treatment planning. So really beam design is, you're looking at directions, beam directions and trajectories chosen such that you're taking into account the 3D anatomy of both the patient, the target, and any normal tissues around there. And so, in this little diagram, I really like it because it shows, where the beams overlap, that's where your high dose region is going to be. So, you have a normal structure here. You can have one beam going through it. That's no problem. You aim the other beam such that you avoid that. Maybe add a third beam, fourth beam. And so you can see as you add non-opposing beams, you can start to shrink that high dose region ever so more around the PTV and reduce any dose to normal structures. Now, aperture design is a little bit different as well in 3D radiation therapy. So most LINACs will have something called an MLC, or a multi-leaf collimator, and that's basically like a robotic aperture device that basically can change shape on the fly into very complicated shapes. And so you can see, as the radiation, this is mounted on the head of the LINAC, and as the radiation comes through it, these metal leads will block the radiation, and the opening will let radiation out. And so whatever shape you design up here, will kind of fall onto the patient. And this designing of these apertures, these openings, are actually done most of the time by the planner, not the physician. Whereas in 2D, the physician would draw out your portals, draw out your blocks. In 3D planning, often this is left to the discretion of the planner in order to create and shape that dose cloud around your target. And lastly, one of the biggest differences is, if you're kind of treating the 2D era on cobalt machines, you only have one energy. Moving to LINACs, you're probably going to have access to several beam energies. And that's usually determined, you choose your beam by how much depth, how deep you want the dose to go. So basically you'll choose higher doses higher energy beams for deeper doses, and how much surface sparing you want. So again, as you go into megavoltage, the higher megavoltage beam you have, the more skin sparing you're going to experience. Okay. So moving on, let's say you have a nice treatment plan. Part of that is dose calculation. So again, in 2D era, they were usually kind of just calculated lookup tables. Maybe, you're accounting for field openings. Maybe you can do some rough estimation of how much lung there is and adjust for that. But this was very kind of a little bit more crude. Moving to 3D, we start off again with that CT scan we acquired after simulation. And we take every single beam interaction that we can get. Models are all very different, but in general, you will take a beam and you will traverse it through the patient's CT scan, and you will adjust that dose that gets deposited depending on whether it's in tissue or lung or in bone, or whether it's on the cusp of both. And it does this very sophisticated calculation from every beam for every little beamlet, adds this all up, and it creates what you would call a dose cloud. Okay, over here. And these dose calculations can be very sophisticated, and they can include a lot of different correction factors, machine scatter, electron contamination. These are very sophisticated, but one of the things I want to kind of stress is that when you see a dose on the screen from a 3D treatment planning system, there's a temptation to look at these numbers, and they're very precise numbers, so 95.6%. You kind of you're tempted to take these as the absolute truth, but in reality, this is still a model, and it still has limitations most of the time. And so you have to be careful of when you're evaluating, when you're looking at these doses or calculating these doses, of what you're looking at. So, you kind of never trust dose inside or near inhomogeneities or big inhomogeneities. So something like very dense bone or very inhaled lung, skin surface, that you would be kind of cautious of dose in those areas, especially when you're using small fields. So this graph here gives you an idea. The black lines are a PDD of water and then a slab of lung. And the black line is sort of a Monte Carlo calculation, which is sort of the best we can do. And you can see, really, depending on the different algorithms that you have, some are very accurate and some are not. You're looking at, at a 40–50% dose error, which is huge. And this did have a clinical impact. I know I worked in British Columbia for a long time, and we did, when we first did our SABRE, these very high dose, small field lung plans, we actually had a lot of local control loss because the algorithm that we were using overestimated how much dose we were giving. And in reality, the dose wasn't there, and we failed on a lot of patients. Moving on to plan assessment. So now that there's a calculation, the plan looks good, we give it to the doctor, and the doctor's aspect in 3D, or the doctor's tasks in 3D plan evaluation and assessment, are much more involved. And this is a huge stumbling block for a lot of clinicians that we've looked at. There's just a lot of information in 3D treatment planning to evaluate. And it can be very difficult to kind of quantify the dose, right? It's just a cloud, it's just a shape of dose in that 3D anatomy. It's hard to kind of envision it, it's hard to quantify it. And so there's a lot of helpful concepts that, again, those ICRU reports give you. There's this thing called the DVH, which I'll talk about, and you can look at the dose distributions. But as you move from 3D into IMRT, this becomes absolutely vital. Again, so I want to stress that the skills that you develop here, moving from 2D to 3D, and how comfortable you get with them in 3D, they'll pay off when you move to IMRT and more advanced treatments. So ICRU 50 and 62 again come up. They give you a lot of concepts of how to evaluate plans and how to standardize plans. So for example, you have a PTV, a target that you're giving dose to, and you have a prescription. Well, the dose is always going to be a little bit wavy. Well, what's acceptable? So it gives you an acceptability criteria. You can go up to 107 or down to 95% of your prescription dose within that PTV, and that will be appropriate. Gives you an idea of what a hotspot is. So a meaningful clinical hotspot is probably something that's larger than 50 millimeters around. If your hotspot is a couple millimeters, it's probably not clinically significant in the 3D era. So it gives you a lot of tools to kind of how to learn to assess these plans. And one of the biggest tools that you'll get for 3D plan assessment is this dose volume histogram, or a DVH. I'm sure some of you have heard it, but if you haven't, it's basically a way to take something like this, which is a complicated, dose cloud and structures, and it compresses everything into a little graph. And it's a way to summarize and quantify these dose distributions. So basically, it summarizes the whole distribution and it puts numbers down to it. And it's pretty simple. It's hard to explain, but it's pretty simple to use. So basically, a DVH is that volume of a structure on the left-hand side and the dose on the right-hand side. And so let's say your question is, how much of the rectum is receiving at least 30 gray? So this line here represents the rectum. So you look up from 30 gray, and then you look up over onto the volume of the structure, and you can see it's about 25% of the rectum is receiving 30 gray. 40 gray, only a little bit of the rectum, maybe, 3%, whereas 10 gray, the whole rectum is getting 10 gray. So it gives you an idea of what that dose distribution looks like, and that gives you the ability to put numbers to it. And as a result, it gives you the ability to compare different patients to each other, and eventually to clinical trials and things like that. So in general, normal tissue structures, you want to push them this way. PTVs and targets, you always want them up on this side, meaning they're getting their full dose and it's a nice steep dose. But again, like I said, there's pitfalls to the DVH. You can't just look at the DVH. You always have to look at what the DVH is representing. So if you do have any hot spots, well, you have to look at where those hot spots are. If there's cold spots, are they in a clinically significant spot? And also, the DVH can be tricky because if you didn't contour something in the contouring step, it's not going to show up on your DVH. So looking at the dose distribution is always vital, and you can make sure you don't want to skip that. Okay, so finally moving to delivery, where everything kind of comes together. And again, I think I've already stressed this enough that being accurate with your positioning is absolutely vital as you move into 3D radiation therapy and then ultimately for IMRT. Any sort of misalignment is, basically undoes everything that you've done and actually can, detrimentally be a detriment to the patient. So the treatment approach and the planning approach all have to kind of match in order to benefit as much as you can. So your imaging on the machine, the immobilization on the machine, and any delivery tolerances all have to work together in order to basically be able to shrink that dose around your targets. A big difference between delivery for therapists a lot of the time is that moving from 2D to 3D, beam arrangements no longer make sense. A lot of time in the 2D, you can see where you're going to shoot, and the therapist can verify, yes, we're treating a pelvis, this is obviously a pelvis. In 3D radiation therapy, often beam angles can come from the opposite side of the patient. The aperture, the shape of the opening of the MLC can be very kind of tricky to figure out. So it's often difficult for therapists to check that these are the correct patients and nothing's going wrong. And so you have to, and now that you're pushing the dose higher and it's a lot tighter, it's going to lead to serious errors. And the delivery, step is the last step in our chain, and it's the last step for defense. So there's got to be checks and balances that we implement moving from 2D to 3D that really make sure that we're not making any mistakes all the way through. And as a result, I really want to stress this, that 3D treatments should take longer and will take longer. And I know in a lot of clinics, this is a huge point with clinics treating a ton of patients, but my kind of takeaway is that you have to learn to slow down. 3D and ultimately IMRT will have a ton of opportunity to improve your patient outcomes, and that's why you're here. But there is a cost to it. There's time on the machine in order to get imaging and precision to make sure that what you're treating is accurate. There's a lot of time and expertise that go into simulation, contouring, and treatment planning. And there's higher doses, so there's higher chances for incidents. And really, ultimately, for clinics that are transitioning, our biggest recommendation is to slow down during this transition. Because basically, in order to benefit your patients, every step of the way has an implication on every other step. And you have to have fidelity between the beginning of the chain and the end of the chain in order for things to really work in unison. And throughout the whole thing, clear communication and understanding of each step is absolutely vital. So I think I'm going to turn it back over to Layth now to kind of talk about some of the success stories.
Thank you, Piotr. But before you speak, Layth, we did have some questions that came up.
Sure.
So Piotr, I believe for some members in the audience, this is their first time seeing the ICRU or ICRU.
Okay.
Could you explain kind of like what is ICRU? Is it a document? And what does it have?
So the ICRU is basically an organization gives you a lot of standards, international standards and international guidelines that are quite first principles, kind of basic, that really sets the standards of radiation therapy. So the ICRU is an organization. They do a lot of like measurements and reporting, but these two reports, ICRU 50 and 60, really kind of introduce the 3D concept and are the basis of how we do 3D treatment planning. So these are reports that you can look at, and I'm sure there's many of the sessions that are going to follow this are going to touch on this. But really, they're two documents from this organization called the International Commission of Radiation Units and Measurements that basically set the foundation for 3D radiation therapy, some of the concepts that we use almost on a daily basis.
Okay, thank you.
That helps.
Yeah, Dr. Al-Karim, hopefully that helps answer your question. And then we have a question from Fadi, a medical physicist from Egypt, regarding the PTV and the DVH. Do you recommend V95 less than 95% or D95 less than 95? I think this is maybe a common question.
Yeah, it is a common question. And I think I don't know if there's a consensus, to be honest. I've worked in 3 separate clinics and each of them have their own consensus. I think for me in the previous 3D era, I think the V100 covered by 95% was sort of what we aimed for. But I think it's up to you. yeah, up to you. V95, 95 works as well. So I think it's, open to debate and open to assessment for your individual clinic of how you want to. But I don't think there's a consensus, to be honest.
Great, thank you. I would agree. Are there any other questions before we move on to Dr. Layth? We have one question. What is the optimal LINAC number per million population to have a reasonable waiting list?
Oh, wow, that's a great question. I could not answer that off the top of my head. I'm sorry, but we can maybe get back to you.
I think I have a little bit of an insight. So the IAEA recommends 1 linear accelerator per 250,000 population. So that is 4 linear accelerators per million population. Now, I've also spoken with many other countries who are far below the recommendation. That's something that only like rich countries could afford. But with that estimation, it estimates that each linear accelerator is treating around 300 patients per year. And yeah, you're shaking your head because we know that in a lot of our countries, each machine is actually treating many more than 300 patients a year, maybe 500, maybe 700, maybe 800 patients per year. So a country may be able to do okay with less linear accelerators per million, but there's always a trade-off. In order to treat patients quickly, sometimes you can't treat them all with treatments that take a long time. If you want to get to the point where you can treat every patient with 3D or with VMAT, it will take more time to plan each treatment. And so you might need more linear accelerators per million. Hopefully that helps answer your question. Good. And there's a comment from Nala. Does this mean in Sudan we should have 160 linear accelerators? I think it does. I think in the future, this should be the goal of the country. That's with the current population. Just think about how the population is going to grow in the next 10 years or 20 years. So we're already behind, but the best we can do is work with what we have right now and continue raising awareness for the importance of radiation in our regions. Thank you.
Ben, I think I'd like to add that, as you move forward towards more sophisticated treatments, those, like you said, those times are going to get slower and there's much more involved. And so I think, looking further ahead, I think is much more important, and planning now is a huge, huge issue.
Great. So yes, Dr. Layth is now going to share a success story of a center that was in your shoes and that now has transitioned.
Okay, thank you. I may just also comment on the question about the need of countries based on their population. Actually, this has been addressed by many scholars, and they also included the economic status and the population and the incidence of cancer and the cancer patients that are in need for radiation therapy treatments. And this rate can be ranged from developed countries like North America and Western Europe to about 8 machines per million, and to less in Eastern Europe to about 4 or 5 machines per million. The IAEA and WHO recommendation used to be 2 machines per million, but the recent recommendation by the IAEA also make it down to at least 1 machine per million population. And there's another calculation which is based on the number of the cancer patients per year incidence, and that is about every 500 cancer patients, will need 1 radiation machine. Every 500 cancer patients will need 1 radiation machine. This is for the general countries as an equation. And for example, a country like Iraq, who's now about 38 to 40 million, Iraq is in need for at least 38 machines, while what we have now is less than 17 machines or about 17 machines. So we have about less than 50% of what we want to achieve. and you can calculate. So a simple calculation is every million of people needs at least one machine. But if you want to have more complicated plans and more time on machines, you have to increase the number of the machines, and you may reach that every 1 million needs 8 machines, as in the United States, for example. So return back to the completion of the slides here. Basically, I was like in starting my journey in 2002 in the radiotherapy and cancer care in general. I was in Iraq, and we used to treat cancer patients with cobalt machines, and with the technology of simple cobalt, like 1D, even sometimes without treating, without simulator. So I remember in the clinic, I used to measure the chest wall thickness and make like a shadow on the X-ray, chest X-ray, simple chest X-ray, and then I will go to the like radiotherapy and physicists and the planners to make the calculation based on the depth of this lesion on the center of the chest, for example, and then we'll make the simple calculation. So that was for the like 1D era. And then I moved to Jordan in January 2006 to train at the King Hussain Cancer Center. And this center started also with the simple 2D. And I remember, next slide please. I remember that I started the residency. We used to like do simulation at the conventional simulator. And then after that, we'll do like the calculation based on the like distance measurements, and we will like arrange the shields by like our hands and based on the film from the conventional simulator. And in the middle of 2006, like the department established a special CT simulator, and after that we started to have the 3D concepts, and later on in 2010 the EBRT concepts. And after I left the King Hussain Cancer Center in 2011, the department also like invested more in the equipment, and now they are doing the VMAT and SBRT and SRS. So many advances now are available at the King Hussain Cancer Center. So this patient is one of the patients that I shared in the treatment. He was like a middle-aged person, 20-something years old, presented with the medulloblastoma at the fourth ventricle. And so that was from the first month of my training at the King Hussain Cancer Center. And here you can find the medulloblastoma tumor in the MRI. So this is like the X-ray, the conventional simulator will take the X-rays from 270 degree and from the 90 degree, two laterals for the skull, and then we made a shield of this is like a shield of lead, and it's customized for each patient. And then after doing this step, we will re-book the patient for check simulation. And then after checking the simulation, usually the treating physician sign as an okay. So we are covering the cribriform plate, we are covering the base of the skull, we are covering the whole, like the meningeal sac around the skull, and we are covering the also the cord, and so we are on the aim of covering the whole meningeal sac. Next slide, please. And this is the lower part. Because the patient is medulloblastoma, so the plan is to treat him with the craniospinal radiation. So on the left side, this is the upper spinal part, and on the left, and here on the right, on the left side, you will see that the block is covering the limits of the field. There is no need for a shield. While on the right side, the lower part of the spine, we need to have a block because we don't have the MLC at that time. So we have like this shields covering the area that we want to spare, for example, the kidneys bilateral, and then it will end up with the sacral pad. So we are like covering all the regions that we want to irradiate. So this is a simple 2D plan and 2D treatment. We are like covering all the risk organs, but on the expense of also irradiating more normal tissues. And then we moved later on to the 3D era and concept. And this is a patient who I like shared in the management plan on the second year of my training in 2007. And he is a child with the retinoblastoma bilateral, but on the right side we want to irradiate the right side. So this is a CT scan of the patient, and this is like the red cam of the patient showing the disease bilaterally, and this is the CT scan, CT simulation scan, showing the mask and also the dots, the BBs at the mask. The plan was to offer 45 gray in 25 fraction. Next slide. And this is the plan from different angles, like gantry 340, gantry 15, gantry 35, gantry 325. And this is the MLC with the 3D conformal plan. So 4 beams we used, 4 fields. And this is the 3D conformal plan of irradiation. And this is the DB edge. We have to contour all the like target organs and the risk organs. And this is just like a story of the King Hussain Cancer Center. It was established in 1997, and then it like moved to be more comprehensive cancer center in 2003, with the vision and mission to be like a leader of in cancer care in the region. And lately they also expanded the original like buildings with another 2 buildings with a bridge in between. So, and it became like kind of the tertiary comprehensive cancer care and research center in the Middle East. So this is just short story of success. It is not governmental organization, not for a profit foundation, established by a group of people and supported by the royal court in Jordan. And so they did an amazing job, really. They did.
Piotr. So the take-home message today is there is a way for improvement, and we have a way to make our decision and plan. And not just a radiation plan, but plan for our center, plan for our patients, and plan for our country. I think Dr. Layth is a great example showing treatment of a person's right eye. This would be very hard to do with 2D treatment. Maybe impossible without causing really bad dose to the pituitary stalk, the optic nerves, many critical structures. And so we're hoping that as you are able to transition to 3D, it will open new possibilities, new capabilities for you to help your patients in tricky situations. And it's our pleasure to be with you during this important transition.
Any question?
Yes, if there's any questions today or tomorrow or next session, feel free to type them. We know it is late in your time zones, but we really feel your motivation and dedication. And we thank you very much for joining us tonight. And yes, I'll allow anyone who wants to speak to either type, or if you want to unmute your microphone to say something, feel free to do so at this time. Okay. Any more questions? And I'm very happy to see some of you all in a room together. sharing this conference. So hello to everyone. And Shada, thank you for providing the translations during the presentation today. Very helpful.
I didn't translate much. السلام عليكم جميعا. As much as possible أي حدا عنده سؤال باللغة العربية، إذا أي حد في شغلة ما فهمها نعيد الكلام باللغة العربية إن شاء الله. وخلال المحامية we will يعني نوقف. وشكرا جزيلا لكم in the next other sessions.
Good. We will be in touch with the clinic coordinator at each of your centers. I believe the next session will be this Sunday at the same time. Same link, same place.
Thank you, guys.
Thank you, Dr. Dubrowski. Take care, everyone. Feel free to leave now. Good night.
PM